Sanjay, thank you for this kind invitation. This is a wonderful audience, and I'm happy to talk about a topic that it's near and dear to me. So what I'd like to do is begin by talking about what it is a biomarker. And I think this is really, really important for us to understand so that we can actually use these biomarkers better in our clinical practice. And then I'll begin with clinical prediction models, which are things like FIB4, NAFLD, fibrosis scores, and then transition to talking about imaging biomarkers, and then conclude by talking about sort of the new and up-and-coming serum-based biomarkers. And this has a lot to do with the amount of clinical data that's behind this. So with that, what is a biomarker? So biomarker, and this is the FDA regulatory definition, a biomarker is an objective patient characteristic that can be measured as an indicator of a normal biological process. It can be a measure of an abnormal or pathogenic process, or it could be a biological response to a therapeutic intervention. So essentially what this means is that a biomarker represents a pathophysiological or a physiological process that we can then measure using a standardized tool that has then been evaluated in that disease process. And there's many different types of biomarkers. And what biomarkers should do is they should fit for purpose. And this is really, really important because there's many different types. So we can have a normal physiology biomarker that identifies people who may be at risk. So these could be genetic mutations such as BRCA, or it could be HPV 16 or 18 that increases the risk of cervical cancer. They can actually then lead to subclinical pathologic processes or altered physiology. And then eventually that translates into clinical disease. And this is where most of the research effort for fatty liver disease is in sort of diagnostic biomarkers. So can we actually identify people with fatty liver disease non-invasively? And then if we can identify them non-invasively, can we actually risk stratify them? What's their likelihood that they will have a clinical event over time? And in doing so, we can separate the people who are at risk for liver disease, who may require more intervention, from people who are low risk for intervention, and as a result can be followed less aggressively in clinical practice. And then, unfortunately, we don't have any significant therapeutic options for treatment of fatty liver disease. But if there were, and there's a lot of effort towards this, then we need to develop treatment-specific biomarkers. So these are things that actually show us a change in physiology, whether people are responding to therapy, if that therapeutic response is adequate. So these are biomarkers such as INR or looking at alkaline phosphatase in patients with PBC. And then we need biomarkers that will show us if patients are getting better or getting worse. And then, so these could be things like echocardiogram in a patient with heart failure, where we can follow them. And then we need to be able to follow surrogate clinical endpoints. So in fatty liver disease, unfortunately, we don't have that yet. But an example of this may be alkaline phosphatase, again, in patients who have underlying PBC, because if their alkaline phosphatase improves, we know that's associated with improvement rather than having to do a liver biopsy. So this is the different types of biomarkers that actually, from a regulatory perspective, are important. And again, our emphasis is sort of from a fatty liver disease in diagnostic biomarkers, the ones that identify clinical disease. And this is, again, important because most of the literature that's been published so far doesn't do this well. And I'll elaborate on this in the next few slides a little bit more. But before you can actually develop or you can put forth a biomarker, it's very important to identify what is the clinical need for it. So certainly we can identify patients who may have hepatic steatosis, but what is the need of that? What is the clinical impact of being able to identify somebody with fatty liver disease if we have limited tools to actually deal with that? And then we have to be able to define what's the context of use. Well, how is that biomarker going to be used? What is the clinical problem that biomarker is going to address? What type of biomarker is it? Is it a prognostic biomarker? Is it a disease monitoring biomarker? Is it a prognostic biomarker? And then once we have sort of established those two key elements of biomarker, then we need to identify what is the impact of that biomarker on a patient, right? So if we have a biomarker that's very, very good, we can identify patients who are going to be at risk for disease. And if we identify those patients, they will certainly benefit from changing the trajectory of the disease. But what about misidentifying these patients? What about patients who actually are you misdiagnose them? Now they may have to have a liver biopsy. They may undergo unnecessary clinical screening. So there's significant consequence of being able to falsely diagnose somebody with a disease. But the flip side is if you can also have a false negative. So what's the consequences of missing a diagnosis? So these are things that really have to be taken into consideration when we talk about biomarkers. Because oftentimes what we see is area under the curve. We see, sensitivity, specificity, positive predictive value. And when we read these papers, we look at those factors and we say, well, this is a good biomarker. But if you look carefully, most of the vast majority of the publications have really not established the importance of these factors. And then once you have established these things, then you actually have to design a clinical trial with evidentiary criteria. What that means is that it uses all of these criteria then to develop a trial where you can then look at that biomarker and how it addresses all of these factors. So this is a key part of biomarker development. So let's understand a little bit more about the data that I'm going to show you. So if we look at it, what the data shows, it shows us area under the curve, it shows us sensitivity and specificity. And this is important because sensitivity, we want a test to be sensitive so we can pick it up, but we also want a test to be specific. So, what we get is what we're looking for. But if you look at it, a lot of times what papers report is something called a Uden index, or where the sensitivity and specificities intersect. And we use this clinical value, we use this value in our clinical practice. And I will give more concrete examples of this later on. But the problem is all this does, it maximizes the sensitivity and specificity, but it doesn't, so statistically, it's a good value, but clinically, it's not a good value. Because again, when we have a test, we want to use the test for one of two main reasons in our clinical practice. One is we want to rule a disease in, or we want to rule a disease out. So if we want to rule a disease in, we want a high positive predictive value. Or if we want to rule it out, we want very high negative predictive value. So by optimizing the diagnostic performance of that test where these two lines intersect, we're actually not using it how we would, the value is not clinically relevant to us. And that's really, really important because the vast majority of papers actually don't give you these values that are clinically useful. The newer papers have started to change that, but most of the old papers don't do this. Now that we have that biomarker, what a biomarker is, what's the purpose of it? Let's look at what are factors that we can then use to actually quantify and that are relevant to clinical practice. So steatosis is clearly important. Inflammation is important. Fibrosis is important. And these are key histological parameters. But of all of these parameters, the only one that has been consistently linked to clinical outcomes or endpoints is fibrosis. So that's why a major effort in biomarker development is towards being able to risk stratify fibrosis. I do want to add a little caveat here is that the diagnosis of NASH is also very important because multiple studies now have shown that presence of NASH is an important predictor of hard clinical outcomes, such as likelihood of a hepatic decompensation, such as need for liver transplantation, such as death. But again, that's something that's been, unfortunately, all the biomarkers that have aimed to detect NASH non-invasively have been disappointing. So I'm just going to focus on fibrosis. And so this is another way of looking at the same issue that I just mentioned on the slide before. If we look at the spectrum of liver disease, so we start with fatty liver, we have NASH, we get NASH with some advanced fibrosis, and that fibrosis can then progress in cirrhosis. So the one that's closest to liver-related events is NASH cirrhosis. So hence, most of the biomarker development aims to identify patients at this point. because this is the one, if we can identify this one, we know that a number of them will go here. These group of people going to this it's less well known, and we don't understand the time event as well. So that's why the emphasis of biomarker development is this patient population. And again, this shows liver and non-liver complications in patients with fatty liver disease. And you can see, again, liver complications are all sort of clumped together towards the end, whereas non-liver, such as cardiovascular, kidney disease, cancers, all spread out evenly throughout that. Now, there's two biomarkers priorities. One is what is the risk of liver outcome? So this is critical to decide who's going to need therapy, who's going to need surgical transplant evaluation eventually, who's going to need further monitoring. And then is the disease, so this is sort of when people come into our clinic and we see them for the first time. And the second is whatever we're doing, weight loss, vitamin E, is that actually changing the disease trajectory? So over time, are we seeing a movement from here down this way? So those are the two, or are people going to go this way? So those are the two major priorities of biomarker development, is being able to risk stratify patients, and then more importantly, see how they're changing over the course of their clinical care. Now, we can use several pathophysiological mechanisms for biomarker development. Now, I want you to think of this as a key concept in liver disease, and this is not just fatty liver, but all liver disease. There's disease activity, and then there's fibrosis. And if you think of this as a car or sort of driving somewhere, disease activity is how fast you are going. And fibrosis is how far you have traveled and how close you are to your destination. And disease activity, there's several different physiological processes that can be measured in that, but they haven't, the omics approach, so metabolomics, lipidomics, all of those approaches have sort of started to focus on that. Whereas the fibrosis has been the center of emphasis with regards to imaging, clinical prediction models, or non-invasive fibrosis models, and even some of the blood-based markers. So that's where most of the thing is the fibrosis, or how close we are to our destination. Now, this is just a summary of what I talked about, and just to kind of put it in more clinical context. So if you look at it from a susceptibility perspective, which are patients that are going to get fatty liver disease and are going to go on to develop it? So looking at PNPLA3 and other genetic markers. And again, the information is so sparse, and the lack of clinical correlation is so few that we really can't use this. So the likelihood that we're going to be able to identify a susceptible individual and use it as a key biomarker is fairly low. The next question is fatty liver disease present? We do have biomarkers that can do that. So ultrasound, for instance, sometimes liver enzyme, but we don't really need a biomarker for these patients, because we know that if they have a certain clinical profile, if they're diabetics, if they're obese, if they have hypertension, if they have dyslipidemia, hypertriglyceridemia, we know their likelihood of having non-alcoholic fatty liver disease is relatively high. So we don't need to put all of our effort into identifying patients who have fatty liver disease as a biomarker, because we can do that fairly well in our clinical practice. So the next thing is, once we know that somebody has fatty liver disease, what's the risk that they're going to have an event? Now, this is critically important, because if we can figure out who is going to have an event, that's who we target for intervention, lifestyle, clinical trials, and so on. So it's a key emphasis in being able to identify. And this is patients with NASH who have some degree of fibrosis, and that degree of fibrosis keeps changing. Initially, it was cirrhosis, then advanced fibrosis, and now even moderate fibrosis. And then, as sort of we progress along that slide that I showed you with different types of biomarker, can we match a patient to the drug? Now, this is something that we don't actually have a good drug, so it's more difficult. But there is active work with pharma companies to be able to develop biomarkers that can identify patients who will then respond to the medicines that we have. And then finally, is the disease trajectory changing? This is important because even though we don't have a drug, there may be certain interventions that we have access to that may not be FDA approved, such as pioglitazone, vitamin E, weight loss therapy, that we want to know after we have intervened on them, what's the likelihood that over time they're going to either progress or regress. So if we were to classify these different types of biomarkers in the clinical need right now, I think the most important is that we need biomarkers to be able to risk stratify patients. And then secondly, we need to be able to identify who's changing, what their disease is doing over time. And then the rest would be nice, but I think those two are the priorities. Now, there's different types of fibrosis models. So the ones that have been around for a while are the clinical prediction models, and these were developed initially in viral hepatitis and then have been validated extensively in non-alcoholic fatty liver disease. Then, as we got better with imaging technology, imaging-based modalities such as vibration-controlled transient elastography, MR elastography, and more recently, shear wave elastography, those are proving to be very promising biomarkers. And then finally, there's sort of serum-based biomarkers. So ELF, lipidomics or OWL, metabolomics. And these things are actually relatively novel with very little data. But it's something that offers a lot of promise because we can do this based on blood work rather than actually having to have an additional scan done on them. So let's start by talking about clinical prediction models. And this is an example of clinical prediction models that we oftentimes use in our clinical practice. These are scores like FIB4, APRI, NAFLD fibrosis score, AST to ALT ratio. And what they do is they use common known clinical predictors. So age, diabetes, platelets, AST, ALT ratios, and they put them into a clinical model. And then we oftentimes use that model to predict who may have liver disease or advanced liver disease and who may not. And as you can see, this is the diagnostic performance of these clinical models. And FIB4 and NAFLD fibrosis score, they're all sort of very similar. But what I want to have you focus your attention on is their negative and positive predictive value. So positive predictive value being is sort of a rule-in test. You're diagnosing the disease. And as you can see, their positive predictive value, it's terrible. So this is not a good rule-in test, but they have excellent negative predictive value. And you can see, so the way these tests can be used in clinical practice is if they have a low value, you can be 93% certain that they don't have any significant fibrosis or advanced fibrosis, and they don't necessarily need any additional workup. And this could be a low risk patient. Whereas if they have a high value, you're about 40% certain that they have something. So in those patients, you cannot definitively rule out disease, so they need a biopsy. So by using this methodology, you can risk stratify patients in practice who may need additional workup versus who can be followed non-invasively. So these models, clinical prediction models, tend to predict presence of advanced fibrosis. And they can actually also predict who's going to progress to advanced fibrosis over time. And this is actually the only study that's linked to histological parameters. But this is something we need, and there's active efforts into validating these biomarkers, not only to histology, but more importantly, to clinical outcomes. There's some data that attempted to link these to outcomes in FIB4 and NAFLD fibrosis score was associated with the risk of clinical outcomes, but it was a smaller cohort with incomplete follow-up. So again, these are things that are being evaluated, but these are potential things if you don't have access to more advanced technology or MRE, for instance. These can be used in clinical practice to risk stratify patients. There's a lot of published data now on vibration-controlled transient elastography. So I want to spend a little bit of time really understanding what it is and how do we use it. So what vibration-controlled transient elastography is, there's a probe, and that probe creates a shear wave, and this wave then travels through the liver, and it uses an echo pulse to then measure the speed of the wave. And the idea is that if you have a patient who's fasting, who doesn't have underlying heart failure, significant inflammation, alcohol use, that the majority contribution to the stiffness in the liver comes from fibrosis and fibrosis alone. So if you can measure that, that's a reflection of hepatic fibrosis. And this is the concept that's leveraged in Fibroscan. And this is the median liver stiffness values stratified according to fibrosis stage. And the reason why I'm showing you rather than actual cutoffs is if you look at it, stage 0, stage 1, stage 2, there's a significant overlap in these box plots. But more importantly, there's patients who have no fibrosis who have a liver stiffness value of 75 or 50 or 25. So these are going to be false positives. Same thing, stage 1, stage 2. But as you get to stage 4 or cirrhosis, there's a significant differentiation between these rest of the parameters. And again, you see some of that differentiation as patients progress to stage 3 fibrosis. So what this shows is visually, Fibroscan is much better at predicting disease at the end of the spectrum than it is predicting disease at the beginning of the spectrum of fibrosis. And this is what those cutoffs are. And what this shows is this shows mathematically what the concept that I just showed you is that if you look at the area under the curve or the diagnostic performance of Fibroscan, it tends to be much better at higher differentiating more advanced liver disease compared to less advanced liver disease. And the other thing is that, again, this is not a good rule-in test. The positive predictive value here is only about 60% at best, but the negative predictive value can be as high as 90 or 99%. So again, this is an excellent rule-out test, but a terrible rule-in test. And this is a meta-analysis that shows the diagnostic performance of multiple studies that have been published and that use both the M probe and the XL probe. And you can see, again, very good negative predictive value, marginal positive predictive value, regardless of whether an M probe is used or the XL probe is used. So how do we use Fibroscan in clinical practice? So again, as I mentioned before, when we see a patient in clinical practice, we want to either rule a disease in or rule a disease out. And oftentimes when we see patients, we want them to, identify at-risk patients, but, a number of us are doing clinical trials, so we want to be able to identify patients as well. So, in this case, we may focus on sensitivity because we want to be able to know who has the disease and we much rather biopsy somebody who a little extra rather than under so that we can find patients for clinical trials. But in clinical practice, we may be focused on specificity here, where we want to be really, really specific that we have the right person. So, we may set the thresholds a little higher to identify those patients. But again, the negative predictive value, as you can see, is incredibly high. And the other thing is, you can see the cutoffs are very different based on what our clinical question at hand is. So that's the reason why just focusing on Uden index or where the two intersect is not as helpful as sort of deciding how do you want to use the test. Now, Fibroscan is not a perfect test. There are significant limitations of the test, and this is data from the CRN. And what we showed is Fibroscan, unlike prior reports, tends to be a very reliable test in vast majority of patients. And it's only, you have a failed test or an unreliable test in less than 5% of patients. And the thing that contributed to this unreliable test was operator experience. So people who are less experienced with Fibroscan are less likely to have the right answer. If patients have significantly elevated ALT, so they have more active inflammation, if they are of Hispanic background or body mass index. And this has more to do with the body composition. So they actually may have more fat between their ribs and the liver capsule. So the shear wave is traveling further through that fat. As a result, the test may not be as reliable. So it's not necessarily that it's not as reliable in Hispanic. It has more to do with the fat that's present there between the skin and the liver capsule. So we have to take these things into consideration when we're looking at these tests because we want to understand the good and the bad of the tests that we use in clinical practice. We're going to see over the next couple of months to years permutations of how Fibroscan can be used in clinical practice. This is just one example of that. This is the FAST score. And what it does, it combines the liver stiffness measurement with CAP as well as AST. And as you can see, the diagnostic performance for identifying patients with NASH, with F2 fibrosis and moderate fibrosis, it's pretty good. And this is, again, the sensitivity and specificity plot. And you can see, this test can be ruled can be used as a rule out test or a rule in test, where the focus may be negative predictive value or positive predictive value as a rule. So these data are promising and certainly published in an excellent journal, but this really requires to be validated further in multiple different cohorts before we can actually use it in clinical practice. There's data with Agile 3, Agile 4, which actually uses Fibroscan liver stiffness measurement with risk parameters such as diabetes, age, gender, AST, ALT values, platelet counts to be able to improve on the diagnostic performance of these tests. But again, those are very early on, and I think I've only seen them in abstract form, so they haven't even made it to publication. So we'll have to see how these tests perform actually as more data is published with them. Let's move over to MRE, so magnetic resonance elastography. And this is a similar plot as I showed you with Fibroscan. We can see the median MRE box plots plotted against the fibrosis stage. Same concept in the earlier stages of fibrosis. All the values are clumped together, so they're not able to differentiate as well. However, once you get to more advanced disease, the separation is far better. And here is the diagnostic performance. So you can see the positive predictive value is much better with MRE than it is with Fibroscan. But it again is an excellent rule out test with 99% negative predictive value, or 93 for advanced fibrosis, or 86% for significant fibrosis. So again, an excellent rule out test. How does MRE compare with the clinical prediction model? So here is just some of the clinical prediction model. Again, for detection of advanced fibrosis, MRE has excellent diagnostic performance. And compared to FIB4, AST-ALT ratio, NAFLD fibrosis score, BARD, or APRI, MRE tends to outperform these. But again, these tests can, if one does not have access to MRE, these tests do have pretty good diagnostic performance. What about MRE versus Fibroscan? And here we're looking at the different stages of fibrosis. So any fibrosis, moderate fibrosis, advanced fibrosis, and cirrhosis. And what you see is for starting at moderate fibrosis, MRE is better. It's certainly better for cirrhosis as well. So MRE, and this is data that has been now confirmed in multiple studies. The Japanese cohort was one of the first studies that actually published this, but this has been shown in multiple studies that MRE is better than transient elastography for detecting presence of hepatic fibrosis. The other thing that I want to mention is that now there is data with MRE changing over time, whereas that data is lacking with Fibroscan. So what are factors that are associated with more success with MRE than Fibroscan? So as we can see, there's less failures with MRE again, but what I want to really focus on is these things. So body habitus plays a key role. So BMI, waist circumference, chest circumference plays a key role in Fibroscan, which are overcome in patients who undergo MRE. So MRE tends to compensate for the body composition. Lastly, I want to talk about shear wave elastography, and there's two major types of shear wave elastography. One is point shear wave elastography, where there's a single point that is picked on ultrasound, and then using shear wave, we can measure the stiffness in that point. And then there's 2D shear wave elastography, which looks at a two-dimensional area of the liver, and it measures the stiffness in that area. So this is the concept behind point wave and 2D shear wave elastography. There's not a lot of studies on shear wave elastography, and this is one of the recent ones that was just published that actually compares different elastography techniques. And as you can see, and these are the thresholds that can be used in clinical practice. But what I want to draw your attention to is this: for detection of advanced fibrosis, MRE tends to outperform both shear wave elastography and vibration control transient elastography. And there's no significant differences in the diagnostic performance of transient elastography and shear wave elastography. So again, these appear, at least in initial studies, to be similar, but we really need a lot more studies to look at this carefully. There's lots of emerging biomarkers in fatty liver disease that are really exciting. So things like 3D MRE, the inflammation, so multi-scan, and then again, biomarkers such as FAST score, Agile-3, Agile-4. But we really need to better understand, we need more data with these before we can really start to talk more about them. So I just mentioned it for the sake of completeness, but we don't have enough data in these. So this is a slide that shows the comparison of the different technologies that I've presented. Fibroscan can be performed by us in clinical practice. It's pretty good at being able to diagnose both steatosis as well as fibrosis. It has a pretty low failure rate if it's in the right hands. The 27% comes from some of the earlier studies before they had the XL probe. And it's relatively cheap, but the key for this is the point of care. This can be done in our clinic where we have instant results. MRE, on the other hand, it's emerging. It's not something that's widely available for clinical practice. You need a radiologist. There's significant cost associated with it. So while it's an excellent test, MRE has been mainly used in clinical trials, and we're trying to better understand this. In the US, actually, it just got FDA clearance, but we'll still have to wait and see what the cost is and how well it can be used. And then shear wave elastography, whether it's point shear wave or 2D, there's just not enough data for us to actually talk about it. But since it's being done by a radiologist rather than a hepatologist, there's going to be far greater cost associated with it. And then I want to finish by talking about serum-based biomarkers. And there's not a lot on there, so I just wanted to present the concept, and then we can talk more in discussion. So this is ELF that most of us are familiar with. And ELF has been around for a while, and it's just recently that we've actually are starting to better define how it can be used in clinical practice. And this is the data from the Litmus trial, a meta-analysis that looked at the studies that have been published. And as you can see, this is the positive predictive value based on the prevalence of disease. And then this is the negative predictive value based on the prevalence of disease. One thing I do want to note is that the positive predictive value tends to improve based on the prevalence of disease. So if you look at it around a cutoff of around 10, which is what most of us use in clinical practice, depending on if we're in primary care, which is what the green line would look like, or we're in specialty practice, which depending on what kind of practice, will be somewhere up here. It's actually fairly good positive predictive value starts to go up to almost 80%. And then the negative predictive value at the same cutoffs are actually fairly good as well. So ELF is something that seems to be very promising and has been now incorporated into several societal guidelines as a test. So this is an example of how we can use ELF and liver stiffness. And this is a study that showed that if you combine ELF with liver stiffness, you can identify patients with significant fibrosis. Again, these are data that need to be better flushed out and evaluated. But again, this shows theoretically how something like ELF and liver stiffness can be used in clinical practice. There's a lot of interest around lipidomics. We know that fatty liver disease is a metabolic condition. They have a lot of changes in lipid metabolism, different metabolic factors. And what OWL did is they looked at, I think, over 540 different analytes to see if they can identify NASH with advanced fibrosis. And this is looking at the NASH data. And you can see that it actually has pretty good diagnostic performance for predicting presence of NASH. They've done follow-up studies. I think one of them should be out soon that showed not only is NASH good at not only is lipidomics good at identifying patients with NASH, but it also may be pretty good at identifying people who are likely to develop a cardiovascular event. So again, this is a biomarker that holds promise not only in fatty liver disease, but also the metabolic components of fatty liver disease. So this is an example of how these markers, blood-based markers, can be used in clinical practice. And this is the data from a British center where they looked at FIB4 as the initial risk stratifying score of 1.3. People who had less than 1.3, they did not need any additional follow-up, and they could be followed in their clinical practice in primary care. Whereas if they had a high FIB4 score, meaning more than 3.25, they were considered to be high risk for having advanced fibrosis, and then they were referred to hepatologists who then, based on their clinical assessment, did a biopsy. And then if people were in between 1.3 to 3.5, they had a second test. So this was a tiered approach. And patients who had a low ELF, they were then followed in primary care. But people who had a high ELF, then they were referred to a hepatologist. And what this did is actually it reduced referrals to hepatology by 80%. And more importantly, when the hepatologist got these patients and they did a biopsy in these patients, there was a 4-fold increase in detection of advanced fibrosis. So this is really, really important because using this algorithm, what we can do is we can figure out who's at risk and then refer those patients. So these additional 81% of patients who would have been referred to hepatology don't have to go through that extra testing. They don't have to worry about false positives. They don't have to worry about invasive procedures. So again, it not only makes it easier on the patient, it reduces the healthcare burden of working somebody up with underlying fatty liver disease. So this is just an example of how this can be used in clinical practice. And this is how this is how we need to sort of look at papers. Are these papers identifying a clinically useful endpoint or a cutoff value rather than just giving us area under the curve or diagnostic performance? So summary, fibrosis biomarkers in fatty liver disease. It's really important to understand the context of use in how these biomarkers are used. And this context of use will then sort of lead into the next area, which is developing clinical algorithms using this context of use. We need to look at disease monitoring biomarkers. So who's at risk, who's going to get in trouble. And then as we get better therapies, we need to really think about biomarkers that emphasize response to therapy. And these may be something that's disease specific, drug specific. So we may have a biomarker that looks at inflammatory medicines that target inflammatory pathways versus fibrosis pathways versus metabolic pathways. So again, it may be specific to the type of medications, but again, we need a biomarker like this so that patients are not on 3 years of therapy before we know that they're responding. And an example of this is in the PIVENS trial when they went back and did analysis on the cohort to see if they could identify which patients on vitamin E were going to respond to vitamin E, and we found that patients whose ALT levels dropped were more likely to respond to vitamin E. So this is an example of how a biomarker could be used to either continue therapy or stop therapy. And then finally, what we really need is linking biomarkers to clinical outcomes. Right now, all the studies are based on being able to identify patients who have certain degree of fibrosis. But as we know, histology is an imperfect test, and there may be overlap in fibrosis stages. So we really need biomarkers that actually are linked to hard clinical outcomes rather than histology. But these data are being generated. And as we get more data, we'll be able to answer some of these questions better. And with that, I'll end my talk and